Okay. Excuse me. Good afternoon, ladies and gentlemen, and welcome to Grand Rounds. My name is Tom Farden, and I'm chair of Grand Rounds today. It's Christmas. Hooray. Thank you very much to all of you for wearing your Christmas jumpers and entering into the Christmas spirit. Well done. Very good. There's a prize at the end. It is coming up to Christmas. It's very busy on the medical floor particularly, so I can understand why there's perhaps not the biggest audience we'll ever have faced at Grand Rounds today. But that doesn't stop the enthusiasm, and thank you all for coming. Hello to Perth.
Hi.
There you go. Good. Interactive TV. So I'm pleased that we've got the endocrine department who are going to come and speak today, and Craig Thurtell. I've only known him for 2.5 years, and it's only taken me today to work out how to pronounce his name, because I've been pronouncing it Thurtell like Spurtle, but it's not like that. It's Thurtell like endocrine hell, I've understood. So I shall start off with the parish notices, and then I will hand over to Craig. This is a topic. Keep on coming in, keep coming. A second Christmas jumper, everyone. Well done. There you go, very good. And it's a Star Wars Christmas jumper, so double points. This is a slide close to my heart. With a new blood test has been developed that can accurately detect antibodies to lung cancer cells at an early stage, potentially up to 5 years before traditional scans show any damage. The early results of the largest ever randomized trial for lung cancer screening using this blood test in a population of approximately 12,000 high-risk participants was presented at the BTS, that's the British Thoracic Society, winter meeting last week. And results show that 1 in 10, specifically 9.8% of the group who received the blood test, which was 6,000 people, had results indicating the antibodies were present. These individuals were then investigated further with chest x-rays and CT scans to look for lung cancer, and about 5% of the patients were found to have resectable lung cancer. This is a research collaboration between the universities here in Aberdeen, Dundee, Glasgow, Nottingham and Toronto. And here is pictured my friend Stuart, who is the lead respiratory consultant from the East on the project. So congratulations to him for a fantastic piece of work, which actually might see for the first time some advance in lung cancer, which we've been waiting for about the last 40 years. A Dundee-based diabetes support group is adopting 2 research projects at the University of Dundee. The Dundee Diabetes Scotland group has been running for over 50 years and works to support sufferers of diabetes to help manage their condition. The group is now winding down, but is bowing out with a generous gesture to researchers at the university, one of the UK's leading centres for diabetes research. They will give £1,000 each to Dr. Lee Kang at the School of Medicine and Professor Harry Hundal from the School of Life Sciences, both of whom are working at the university to improve treatment for diabetes. The Discovery Days are on the 13th of January. We have many of our medical school newly anointed professors who are going to speak, starting with Sarah Brown and finishing off with others. Tickets are free, and it's on the 13th of January, 9 till 4:30. The last look for the year at our staff development opportunities. The last one is tomorrow, and then there's a new start of new presentations into January. So, on to the main event today. I challenged the endocrine department recently to say we've not heard very much from you for a while at Grand Rounds, and I was immediately met with 3 different opportunities. So they are going to monopolise Grand Rounds for the next little while. And the first presentation will be from Craig, who I've now lost his presentation. He's going to talk to us about a fascinating thing, which is the use of monoclonal antibodies and their effects on the endocrine system. He tells me very excitingly that at the end there's a small quiz. So stay awake, and I'll be out with the roving microphones to see if you've been paying attention. Okay, Craig, thanks very much.
Thank you. Good afternoon, everyone. I first presented at Grand Round 10 years ago as a very frightened medical student, and now I'm a slightly less frightened registrar. The topic I've chosen is to speak about monoclonal antibodies, or MABs, and their effects on the endocrine system. So we're going to start with some very brief, I've said revision, but maybe a revision for some of you and not others, of the pituitary anatomy and physiology to start off with. Quite important just to quickly go over things because it gives a framework to consider the cases. I'm then going to spend a little bit of time going through the endocrine system and looking at the more traditional and established drug treatment-related side effects that we see in clinic and on the ward rounds, etc. Then I'm going to move on to speak about the long-term effects of cancer therapy on the endocrine system and the kinds of patients that we see in our outpatient clinic. Then I'll speak about what monoclonal antibodies are. Then I've got a couple of case presentations that highlight some recent cases that we've been involved with as a department relating to endocrine dysfunction and monoclonal antibody therapy. And if there's a few minutes at the end, I have a Star Wars related quiz just at the very end with an endocrine twist to it. So starting off with the pituitary gland, we should all be reasonably familiar with this kind of diagram. At the top here we have the hypothalamus, and beneath it we have the pituitary gland. We have a posterior pituitary, also called the neurohypophysis, which is essentially just a direct downward extension of this part of the brain up here, and it has a slight different embryological origin to the adenohypophysis, or the anterior pituitary. And these are the main hormones that come from your hypothalamus, which have direct effects on the pituitary gland. Gonadotrophin releasing hormone, we have corticotrophin releasing hormone, thyrotrophin releasing hormone, dopamine, and so on. These are the principal anterior pituitary hormones, and this is what we'll be concentrating on when I go through the first of our cases later on. And highlighted in red are the most clinically important and measured hormones that we check when we see patients in clinic and on the ward. So at the top we have the gonadotrophins, your luteinizing hormone and follicle stimulating hormone, LH and FSH. This substance here, the pro-opiomelanocortin, is just a very large polypeptide that's cleaved to form the following three hormones: your ACTH, or adrenocorticotrophin hormone, beta endorphin, a naturally occurring opiate substance, and MSH, melanocyte stimulating hormone. We have thyrotrophin, TSH, thyroid stimulating hormone, prolactin, and growth hormone. So the ones highlighted are the ones that we spend the most time considering and measuring. And finally, just to mention the posterior pituitary hormones, it's really only vasopressin, ADH, that we concern ourselves about. And of course, an excessive amount of ADH is associated with syndrome of inappropriate ADH secretion, SIADH, which you'll all be familiar with, and deficiency of this hormone, or a lack of its action, would result in the opposite, diabetes insipidus. So now going on to discuss drugs and their side effects on the endocrine system. And this is by no means an exhaustive list, really just a quick run through of the more commonly prescribed agents that we see affecting the endocrine organs. So starting at the top and working our way down, beginning with the pituitary gland, we know that opiates are particularly good at picking off several of your hormone axes, and the ones that they are the best at doing that to are your gonadotrophins, reducing the output of gonadotrophins from the anterior pituitary, and also they can cause secondary hypoadrenalism as well. Antipsychotics, we know, particularly the much older antipsychotic medication, such as phenothiazine drugs, elevate your prolactin due to removing the negative control of dopamine signaling. And in a similar fashion, other dopamine receptor blocking drugs such as metoclopramide, an antiemetic, can have the same effect. Commonly in the thyroid, we see this wonderful anti-arrhythmic drug, amiodarone, which in roughly 13 to 15% of patients treated in the UK will develop some degree of thyroid dysfunction. It can alter your ratio of T4 to T3 by inhibiting the conversion of T4 to T3. That's not genuine thyroid dysfunction, and about 1 to 2% of people, they will develop hyperthyroidism on amiodarone, and round about 13-14% of folk will develop hypothyroidism. Moving further down to the adrenal glands, there are several drugs that are implicated in causing adrenal failure, including the antifungal drugs, ketoconazole, fluconazole, and quite rarely phenytoin and rifampicin. I've cheated a little bit here. The kidney is obviously not really an endocrine organ, but it is the organ that vasopressin, your antidiuretic hormone, acts on. And these are the drugs most commonly implicated in nephrogenic diabetes insipidus, and lithium by far accounts for the vast majority of these, and to a lesser extent the antiviral foscarnet and occasionally clozapine as well. But lithium by far the most common drug causing diabetes insipidus. And we'll likely be quite familiar with the drugs which affect your pancreas and result in hyperglycemia, the onset of diabetes. Glucocorticoids would be the most commonly implicated drug in this category, along with antipsychotics. Calcineurin inhibitors used to prevent organ rejection following transplantation, such as tacrolimus and sirolimus. And finally, the combination of thiazide, diuretic and beta blocker therapy used in hypertension is associated with an elevated risk of developing diabetes. And finally, considering the gonads, I'm coming back to opiates again as a cause of drug-induced hypogonadism. Methadone in particular also has a direct toxic effect on testicular tissue, so another reason for people on long-term opiates with methadone to develop hypogonadism. And of course, anabolic androgenic steroids are also associated with testicular atrophy and hypogonadism. So now I'm going to move on to discuss the long-term effects of cancer therapy on the endocrine system and the types of patients that we tend to see as long-term follow-ups in our outpatient setting. So the survival of particularly childhood cancers is getting a lot better. Back in the 1960s, this was only 30% 5-year survival, and this rose to over 70% by the 1990s. In the UK, there's about 1 in 700 odd young adults are survivors of childhood cancer. It's a similar number in the United States. And if you take a look at this study called the American Childhood Cancer Survivor Study, the CCSS, this study was designed to basically look at what was the morbidity and mortality in people who were treated for childhood cancer and what was causing them to develop disease and die as adults. So after more than 5 years following a diagnosis and treatment for all childhood cancers, they had about an 11-fold increased mortality. The two commonest pathologies seen would be either recurrence or progression of the primary tumour and also the development of secondary malignancies as a result of the chemoradiation that was given, followed closely by cardiac and pulmonary disease, again as consequences of cancer therapy. There's long-term endocrine sequelae in almost half of the patients in this cohort, so it is a very, clinically important group of side effects. The next few slides I'll examine this more carefully, but essentially there's quite wide-ranging endocrine dysfunction in these groups of patients. Disorders to do with the growth of children, the onset of puberty, either being too early or too late, hypothalamo-pituitary axis disease, hypogonadism, subfertility or sterility, thyroid abnormalities, hyperparathyroidism, and also an effect on achieving adequate bone mass. This just really summarises the effects of cancer therapy, and it's mainly cranial radiotherapy on the function of the hypothalamo-pituitary axes. First, thinking about growth, A combination of cranial radiotherapy, spinal radiotherapy is known to impair growth hormone secretion, and it can lead to precocious puberty as well. Spinal radiotherapy results, we know, in impaired spinal growth, and these patients are sometimes disproportioned in their height. Essentially, they have a reduced spinal height. The effect of chemotherapy isn't quite so clear. It may potentiate the effects of radiotherapy, and it may also have a direct toxic effect on the growth plate in children. Growth hormone deficiency is really kind of important across the entire lifespan. It's not just a hormone that makes you grow as a child, but of course in children this will lead to reduced growth velocity if they have cranial radiotherapy for cancer. But in young adults and adults, we know that there are deficiencies in people who are growth hormone deficient even after they've achieved their final adult height. They have potentially impaired quality of life indicators, an altered body composition with less lean body mass and more adipose body mass, and an altered adverse cardiovascular risk profile as well. And down at the bottom here, really any hypothalamo-pituitary axis can be involved in people who've had cranial radiotherapy. Thinking now about the reproductive system, with regards to male reproduction, chemotherapy, local radiotherapy, spinal radiotherapy, and total body irradiation, typically in the context of leukemia treatment for childhood lymphoblastic leukemia, can result in quite a lot of different pathologies that result in subfertility or sterility. And in women, ovarian function is affected by a combination of all these things as well, and can lead to disturbances in menstruation, premature ovarian failure, of course, sterility and estrogen deficiency in later life. And uterine function can be adversely affected with pelvic radiotherapy, and can lead to problems further down the line when these adults wish to have a family. And very briefly, I'll just mention thyroid, parathyroid dysfunction. Radiotherapy to your neck, or indeed total body irradiation, is associated with an elevated risk of both malignant and benign thyroid nodules. It's associated with the development of both hypo and hyperthyroidism. And neck radiotherapy can result in the onset of late onset hyperparathyroidism, which can have a rather prolonged latency. So that's the more traditional groups of patients that we tend to see as follow-ups in our clinic. And now I'm going to fast forward into the modern era and think about monoclonal antibodies as an emerging cause of endocrine disease. So first off, what is a monoclonal antibody? A monoclonal antibody, which is often abbreviated in the literature and just in conversation to MAB, is essentially just an antibody that's produced by a single clone of cells or cell line, and the resulting antibody is essentially, they're all just identical to one another. It was only appreciated in the early 1970s that myeloma cells, the malignant B cell in myeloma, secreted a paraprotein, which is essentially a monoclonal antibody produced in disease. In the mid-1970s, a group of European scientists developed a hybrid cell line. The problem up to that point was that B lymphocytes don't last very long in a cell culture, so it's difficult to use them to produce antibody because they die off after 2 or 3 days. So what this group did was they took the B cells harvested from mice that had been inoculated with whatever antigen you wished to produce an antibody against, and these were fused with an immortal B cell line that were actually just myeloma cells, and this produced what was called a hybridoma, and this cell could produce antibody indefinitely in culture. This group were awarded the Nobel Prize in Medicine or Physiology in 1984. The following year, the US Food and Drug Administration approved the very first monoclonal antibody muromonab CD3, which was used in renal disease for the prevention of rejection following renal transplantation. This drug is no longer used, but that was the first antibody. The naming nomenclature hadn't quite come out by this stage, that's why it's got a bit of a funny name, but nowadays they all end in MAB as part of traditional kind of naming convention of these agents. Sir Greg Winter and his colleagues working in Cambridge refined the process of producing monoclonal antibodies a few years later to effectively humanise them. The early monoclonals were associated with a range of side effects that basically related to reactions to antibodies that the human immune system is not meant to be exposed to. So this reduced essentially the rejection of these drugs when administered to humans. As of 2016, there are now 68 approved monoclonal antibodies in clinical practice that are used in a variety of principally inflammatory and malignant diseases. In 2015, there were, I believe, 10 alone, just in 2015 alone. Again, I'm not going to include a list of all 68 antibodies, and a lot of them are very, very difficult to pronounce. These are the more sort of commonly used ones, and I've tried to include a range of antibodies here to cover most of the specialties that use them. At the top, we have the ones used by our colleagues in oncology. The top two, IPILIMUMAB and PEMBROLIZUMAB, are immune checkpoint inhibitors, and these are the ones that I'm going to focus on when I present our clinical cases in a few slides' time. IPILIMUMAB and PEMBROLIZUMAB are used mainly in the treatment of malignant melanoma by interfering with T-cell function and leading to T-cell activation. This drug here, trastuzumab, is known as Herceptin, and it's used in the treatment of HER2-positive breast cancer. Rituximab was one of the earlier monoclonal antibodies available from the mid-1990s. It's anti-CD20 and is used in haematology for non-Hodgkin lymphoma, as well as other conditions, but mainly in NHL. Infliximab and adalimumab are anti-TNF alpha drugs, traditionally used in gastroenterology and rheumatology for the treatment of IBD, psoriasis, and related conditions. Tocilizumab, again, is used for rheumatoid arthritis and juvenile arthritis. Endocrinologists sometimes feel a bit left out here because we don't really use monoclonal antibodies, but locally in Tayside, endocrinology look after the metabolic bone service. It's not like that across the whole of the country, but we sometimes use the drug denosumab, which is a rank ligand directed monoclonal in the treatment of osteoporosis. And then our respiratory colleagues sometimes use the IgE directed therapy, such as omalizumab for the treatment of allergic or atopic asthma. So now moving on to a couple of case presentations to try and put some clinical context to this problem. So the first case is a 77-year-old gentleman who was diagnosed with a superficial spreading melanoma in 2010. He developed metastatic disease 4 years later with pulmonary metastases and a mental nodule, and he was commenced on monoclonal antibody therapy with ipilimumab, which is commonly used in metastatic melanoma, in September 2014. He had a couple of cycles of treatment with this agent. The third cycle had to be delayed because he complained of early morning headache and a generalised non-itchy rash. He had some abnormal pre-chemotherapy blood tests. That was a planned blood test prior to his third cycle. He had a slightly lowish 9 AM cortisol, and he also had a suppressed TSH with as I'll show later, low thyroid hormone levels. He was commenced on a rather liberal dose of dexamethasone as per the protocol for this drug, and he was referred on to us. So these are his initial blood tests. His UNEs, including his plasma sodium, is completely normal. But as you can see, he has quite widespread pituitary abnormality here. He has a low TSH with a low free thyroxine consistent with central or secondary hypothyroidism. So there's something happening in the pituitary here rather than the thyroid gland, otherwise the TSH would be elevated. He has lowish gonadotrophins, which are inappropriately low, really, given that his testosterone level is only 0.5, so an incredibly low testosterone level. His IGF-1, which is essentially a surrogate for growth hormone. Growth hormone is released in a pulsatile fashion over a 24-hour period several times. So we tend to use IGF-1 as a surrogate marker for growth hormone secretion, although his is normal and his prolactin is a bit on the lowish side as well. He went on to have a synacthin test to test the integrity of his hypothalamic pituitary adrenal axis and his adrenal reserve. And again, he's passed this synacthin test in our laboratory if your peak cortisol following the administration of synacthin is higher than 530. 530? You have effectively passed your synacthin test, although one could say he's only just passed it. So prior to knowing the results of his short synacthin test, we suggested switching him to a more physiological dose of glucocorticoid replacement with hydrocortisone 10, 5 and 5. We started him on some thyroxine for his hypothyroidism, and his hydrocortisone was gradually withdrawn after we found out that his adrenal reserve was adequate with the short synacthin test. Unfortunately, he was admitted to hospital 4 days later following withdrawal of steroid therapy. He'd collapsed with a very, very low blood pressure. His synacthin test was repeated, and this is a failed synacthin test effectively. He has not reached a peak cortisol of over 530, and this result is entirely consistent with secondary hypoadrenalism. So not primary adrenal failure such as Addison's disease, but this is a characteristic pattern whereby you get a little bit of a rise in your cortisol with synacthin. However, this indicates that he has some pituitary pathology, and that's entirely consistent with the rest of his pituitary function tests. He was treated with intravenous fluids, intravenous hydrocortisone, and then put back on oral hydrocortisone. So the diagnosis here is IPILIMUMAB-INDUCED hypophysitis. Hypophysitis essentially just means inflammation of the adenohypophysis, the anterior pituitary. This gentleman had a fairly unremarkable MRI scan, although it wasn't done for some time following the initial presentation. So the initial imaging results or initial imaging may have picked up something, but it wasn't done for some time. Roughly 2 years on, he is still on hydrocortisone, he's still on levothyroxine. He did not wish to have testosterone supplementation, and indeed his latest testosterone level is actually within the normal range, perhaps reflective of partial recovery of his pituitary function. So going back to think a wee bit about ipilimumab itself, it's a MAB directed against CTLA-4, which is cytotoxic T lymphocyte antigen, and it's classified along with pembrolizumab as an immune checkpoint inhibitor drug. CTLA-4 is found on the surface of T cells, as the name suggests, and it's part of the co-stimulatory response for the activation of T cells. If you inhibit the activity of CTLA-4, you remove its inhibitory effect on co-stimulation. So if you block this target, you get increased activation of T cells, and that's responsible for its anti-tumour effect. It's most commonly used in malignant melanoma. The exact reason why it targets your pituitary gland is not entirely clear, but it's thought that there's a combination of a pituitary-specific immune response as well as a systemic activation of T cells. CTLA-4 is expressed by your anterior pituitary cells, and it's thought that by blocking it, you get local complement activation in the pituitary gland, which leads to an influx of leukocytes, and you also have the effect of systemic T-cell activation acting against the tumour, and it's thought that these cells then influx into the pituitary and cause intense inflammation in the hypophysis. And it's reasonably common. This affects, depending on which study you look at, up to 17% of melanoma patients who receive ipilimumab. Looking into the literature, up to 2015, there were 71 cases recorded in the literature. It tends to affect older people. There was a male preponderance, and men were also much more likely to develop adrenal insufficiency. The majority of the cases who developed hypophysitis were being treated for melanoma, as opposed to other cancers. The MRI is frequently abnormal, and I'll show you some images in the next slide of what it can look like. Fatigue and headache were the most common presenting symptoms, which are obviously quite vague and non-specific in fact, and very common in the general population. Pituitary dysfunction is very, very common in these patients. Almost 94% of them require to have at least one of their pituitary hormones replaced, and the most common one that has to be replaced is glucocorticoids. So secondary hypoadrenalism is the commonest dysfunction, followed closely by secondary hypothyroidism, followed by hypogonadism. And this gentleman, of course, has a combination of all three of these things. Unfortunately, in 2/3 of cases, the hypopituitarism is permanent, and it's also thought, there's a suggestion that having a fairly low prolactin at presentation is predictive of non-recovery following withdrawal of the offending agent. This is not our patient, but this is again just a case drawn from the literature. Here you can see an enlargement of the pituitary gland with some abnormal signal here in the pituitary, and following several weeks of hormone replacement therapy and withdrawal of ipilimumab therapy, you get a resolution, or in this case certainly there was at least a partial resolution of the radiological findings. There is also no radiological biochemical correlation in this case, in this condition. There is absolutely no correlation between the severity of what the pituitary gland looks like radiologically and what the hormones do. Moving on to the next case, this is a 30-year-old gentleman who presented initially with a large retroperitoneal mass in 2015. It was thought clinically and radiologically to be a sarcoma. It was resected along with the right kidney a few months later. He unfortunately went on to develop pulmonary metastases on restaging scans, and following review of the histopathology of the initial mass, combined with pulmonary metastases, this was thought to represent primary pelvic melanoma. Metastatic melanoma can be treated with pembrolizumab, and he was started on that shortly after being seen by our colleagues in oncology in July of this year, and again he had 2 cycles of treatment. However, prior to his 3rd cycle, he was admitted to hospital with a 24-hour history of nausea and vomiting. There was no polyuria or polydipsia. He had an absolutely normal set of OBS on his News chart, and he had an unremarkable physical examination, and he was noted to be slim, but that's normal for him. There's a family history of type 1 diabetes in one of his cousins. His plasma glucose is substantially elevated at 24.3, and he is significantly ketone uric. A venous blood gas confirms that he has quite a severe metabolic acidosis, and combined with ketonuria and ketonemia and hyperglycemia, this chap has developed diabetic ketoacidosis. And in a young, slim person, this would traditionally be thought of as being caused by classical autoimmune type 1 diabetes. He was treated for his diabetic ketoacidosis and was discharged several days later on regular subcutaneous insulin with Novorapid and Lantus. We have some further investigation results now. His hemoglobin A1C, which is a measure of his glycemic control over the last 12 weeks approximately, is near normal. This is unusual for someone presenting with type 1 diabetes. 57 is a pretty low number. His C-peptide is undetectable. C-peptide is co-secreted with endogenous insulin from your pancreatic beta cells. If you have undetectable C-peptide, it means that you are not secreting your own insulin. This is highly unusual for type 1 diabetes because patients typically at presentation have a low C-peptide, but it's still detectable because patients with type 1 diabetes are typically still C-peptide positive at low levels at presentation when they develop type 1. His autoantibodies, anti-GAD, IA2, ZNT8, are negative, which again goes against the diagnosis of autoimmunity. If you measure these antibodies in people with type 1 diabetes, at least one of them will be positive in round about 85 to 90% of cases. So they are pretty sensitive at picking up people with genuine autoimmune diabetes. The clinical presentation and laboratory findings were thought to be consistent with a diagnosis of fulminant type 1 diabetes precipitated by his pembrolizumab therapy. So what's fulminant type 1 diabetes? Well, we don't really see it in this country. It's a recently recognised entity. It was identified at the turn of the century and really characterised by physicians in Japan. It is classified as a subtype of type 1 diabetes, or type 1b diabetes, type 1a being classical autoimmune type 1 diabetes. It accounts for approximately a fifth of cases of type 1 diabetes in Japan, so pretty common. The etiology isn't entirely understood, but this is a very rapidly destructive condition whereby your pancreatic beta cells are destroyed very, very quickly. And it's not autoimmunity that causes it. There might be a viral infection that triggers an immune reaction in genetically susceptible individuals, but again, this isn't entirely understood. The key clinical features are an abrupt onset of hyperglycemia, a significant level of hyperglycemia with a near normal HbA1c. Ketoacidosis is common, as it is in autoimmune type 1 diabetes. Absent C-peptide is typical, and the patients are classically antibody negative. And just going back to the geography, there have been the odd cases described in Korea, the Philippines, and one case published from the Netherlands, but generally speaking, it's confined to Southeast Asia. So thinking a bit about pembrolizumab, it's a monoclonal antibody that's also identified as an immune checkpoint inhibitor, much like ipilimumab. Its target is a protein called programmed cell death 1, or PD1, and again this is present on the surface of T cells. Blocking this leads to an activation of T cells in a similar fashion to the way that ipilimumab works. Nivolumab is a similar agent that has a slightly different target, but targets the same pathway as pembrolizumab. And again, it's commonly used in melanoma and also in non-small cell lung cancer. And rarely it's been associated with fulminant type 1 diabetes. Only 16 cases have been described in the literature up to the present day, and that's a combination of nivolumab and pembrolizumab. Most of the patients who developed this condition were being treated for melanoma. And interestingly, there's a mix of GAD or IA2 antibody negative patients and positive cases, although it wasn't checked in one case. So again, quite a heterogeneous group of cases. And some individuals were noted to be high risk for the development of autoimmune type 1 diabetes in the cases that had their HLA markers checked. Some of these people had high risk HLA markers for the development of autoimmune diabetes. So perhaps there's a genetic susceptibility happening here. The etiology is thought to focus on this PD1 pathway. It appears to be an inhibitory pathway for the development of type 1 diabetes. And in mouse models, if you knock this pathway out or you administer drugs that block this pathway, these mice develop essentially fulminant diabetes and have an expanded population of CD4 and cytotoxic CD8 cells in vivo. So to summarise and to finish off, really the use of these MABs is ever expanding. And the immune checkpoint inhibitors used in oncology, I suspect, are going to be offered to an increasing number of patients as time goes on. These are very effective treatments, and I can only see their use widening. And I suspect they're also going to be used in a wider range of malignancies, and they are being trialled in different malignancies, not just confined to malignant melanoma. Therefore, there's the potential to see more immune-related adverse events. Hypoadrenalism and diabetic ketoacidosis are potentially fatal if unrecognised and untreated. So again, important to recognise these conditions that are often presenting fairly non-specifically in these patients with very vague symptoms. And I would advise anyone using these drugs to remain vigilant and consider immune-related adverse events in these patients, even if they develop mild non-specific symptoms. That's all I have to say about monoclonal antibodies, you'll be glad to hear. If there's a few minutes at the end, I've got a little Star Wars related quiz, and because I'm a bit of a geek, we have the endocrinology of Star Wars. Endocrinologists are quite good at making spot diagnoses. Sometimes we can tell the diagnosis when the patient walks from the clinic room, walks into your clinic room, I should say. So this is a challenge of your spot diagnosis skills. So the first patient in your clinic has been referred by his general practitioner with an inability to lose weight and a classically toad-like facial appearance, although you could consider a number of conditions here. Would anyone care to venture what JABA might have? Some of the non-endocrinologists maybe? I suspect Jab is probably hypothyroid, but I probably would have a low threshold for screening him for Cushing's disease as well, etc. The next patient into your room has been referred by their GP with increased nervousness, anxiety, odd behaviour, and I'm not sure if this is a very odd variety of proptosis or if this is just normal for this species. But what might the pathology be here for Jar Jar?
We think he's hyperthyroid.
I doubt it accounts for all of Jar Jar's problems, but maybe a bit of carbimazole might settle things down. Next, this little crowd filter into your clinic room.
Short, hairy people.
I'm not sure if the hirsutism is maybe just normal for these individuals as well as their height, but if there's any particular hormone deficiency that you might think of in these individuals.
Are they just growth hormone deficient?
There's also quite a rare syndrome called Laron syndrome, which is a genetic insensitivity to the action of growth hormone. It's a mutation in the growth hormone receptor that makes it insensitive to growth hormone. So maybe Laron syndrome is particularly present on the forest moon of Endor, I don't know. This is a bit trickier. Your final patient has been referred by his general practitioner with quite non-specific symptoms, but you don't get the spot diagnosis until he removes his helmet.
He's been corrupted by the dark side.
So the striking thing is here is that he has quite a pale complexion with hairlessness, the so-called alabaster skin appearance, and would anyone care to venture an endocrine diagnosis? He might be a bit hypopit, but he certainly seems to have enough energy anyway, so might not need any hormone replacement at the moment. Thank Thank you.
Excellent Star Wars at the end, much appreciated, thank you very much. So, monoclonal antibodies, we've actually got a couple more new monoclonal antibodies in respiratory medicine. It makes us feel like we're actually catching up with the rest of you guys. And unfortunately, Cahill Steele, our immunologist, had to leave, so I can't pin him down for immunological information. But does anybody have any questions or comments they'd like to make about any of what Craig's talked about, or some comments about there? Let me wander over and find you, Professor Leaves. That's not working. That one. Yes, nice day. There you go. Anyway. There you go.
I just wanted to make a comment. You talked about the synacthin test checking the hypothalamic adrenal axis, which strictly speaking it doesn't do. It tests the adrenal reserve, and that's why the first synacthin test was misleading, because it takes a while for the adrenal glands to atrophy if the pituitary is given up. So I think perhaps in the initial test should have been a pituitary hypothalamic test, such as an instant stress test or something like that, would have probably given you the right diagnosis. Clearly, at the beginning, you didn't know how long they'd had the condition for, and therefore a synacthin test might have been appropriate. But I think if you're not sure, then a synacthin test you have to be careful about interpreting. And clearly, it did lead you astray here. So a synacthin test can be completely normal in early pituitary disease.
Oh, another endocrinologist.
Thanks, Tom. Craig, thanks so much indeed. Do you have any idea from the dermatologist how many patients that potentially may become ultimately our way in endocrinology? In terms of
Unfortunately not. Have any of the oncologists come along? I did invite them, but no, perhaps not.
One of the grand rounds we did in here when it was lecture theatre 3 years ago was the dermatologist who talked about malignant melanoma and how excited they were by the onset of these drugs, and they're obviously adopting them. Anybody else got any questions or comments? Yep.
Do you always have to stop the antibody treatment, or do you just replace the hormones and carry on?
Yeah, well, in these cases, the patients have had their MAB therapy discontinued. You could argue that the first patient is achieving some degree of recovery of his pituitary function. So by reintroducing the ipilimumab, you would presume that he would have a recurrence of the same problem initially. The second patient, he's always going to have diabetes, and he's now treated for it. So there could be an argument made that he could have his pembrolizumab therapy continued, because it's not going to make much difference now.
That guy has bad genes, does he not? If he's had sarcoma, then a melanoma, this fulminant thing, it's bad genes, bad luck.
Sorry?
He's got a small child to inherit those genes. 4 kids?
Yeah, that ranges of 1 kid now. He's actually still continuing with it.
Yeah, yeah.
Okay, I'm running up more stairs.
It's just a thought. In both of these cases, the clinical features and the lab results kind of fitted with each other, but we occasionally, as all the endocrinologists know, we occasionally get sort of essentially rogue lab results due to interference with one or other of the immunoassays, and that's due to what we call heterophilic or polyclonal antibodies. And it did occur to me, I Googled it just before I came along, as to whether monoclonal antibody treatments can interfere with immunoassays, and there's basically nothing online about it, which would suggest that either it hasn't been recognised or it doesn't exist.
Not something I've had a feel for from the literature I've read.
Okay. I only have one interesting fact about monoclonal antibodies, and that's that EPILIMUMAB is the most expensive drug in the world. It costs €430,000 a year, and it's for the treatment of paroxysmal nocturnal hemoglobinuria. Yes, right, treats HUS, well there you go, I'm out of date. Is it still as expensive?
Oh yeah.
Yes, £500,000 a year. There you go.
I was going to put it on that list, but I thought, no,
It's
one's
too
ever heard
nerdy.
of
Too
PIs.
nerdy. Right, I'd like to thank Craig for his presentation. I'd like to thank you all for coming. I'd like to wish you all a very early Merry Christmas, but I have no opportunity next week, so Merry Christmas. Thanks for wearing your Christmas jumpers. Grand Round starts again the second week of January, and there's still some places left if you want to talk. There's 9th of February, and then we're into April. So if you've got a burning topic you'd like to talk about, hyperphosphatemia, for example, or a renal thing, then please let me know. Or even acute medical thing, Paul. He's not looked too enthusiastic. Thanks very much for coming. I'll see you around, and I'll see you next semester. Thanks again to Craig. Thank you, Perth. We'll see you. Oh, you've all gone.